Oke, adik-adik,
Fine.
sudah 65 orang. Jadi kita mulai saja ya, sambil menunggu beberapa yang join, mungkin terkendala jaringan. Ya, jadi sebelum kita melakukan kuliah pakar hari ini, mungkin satu orang dulu ketua tingkat untuk memimpin doa kita hari ini ya. Bismillah.
So my friend was saying we're gonna pray before starting the class. If you don't mind, it might take like a minute or two, super quick.
Okay.
Right.
Silahkan Abdul Rauf.
Subhanallah walhamdulillah wa la ilaha illallah Allahu akbar. A'udzubillahi minasyaitonir rajim. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Allahumma sholli ala sayyidina Muhammad wa ala ali sayyidina Muhammad. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Subhana rabbika rabbil izzati amma yasifun. Wassalamun alal mursalin walhamdulillahi rabbil alamin.
Amin.
And
Okay, let's start it. Yeah. Okay, first of all, I would like to say thank you very much to Dr. McMillan, who received our invitation for being a guest lecture with the topic of medication therapy management in pharmacy degree class in pharmacy faculty at Muslim University of Indonesia. And also, I would like to say thank you very much to my friend, my best friend, Apoteker Rudy, as a moderator today. Thank you so much for your helping so that the guest lecture can be held. And because it's 6 o'clock, yeah, to make the time effectively, I invite to the moderator to guide this main session. And time is your please, Apoteker Rudy.
all right, thank you so much, Rizky. Hey everyone. So as you guys know, my name is Rudy, and then I'm currently a fourth year PhD student at School of Pharmacy, West Virginia University, and it's been such a wonderful experience to be here. And today we're going to be discussing tons of things. I really want you guys to be active and with one professor that I really admire. Probably she doesn't know that I do, but anyway, yeah. So I've been Dr. McMillan's teaching assistant for quite some times, basically since the I think since day one I came to United States. Then I got into WVU. I got assigned to be one of her teaching assistant. Teaching assistant basically itu kayak asisten dosen. In bahasa, in our language, we call it asisten dosen. Without further ado, I would just give the chance to Dr. McMillan to start the presentation. And I would like to again emphasize that you guys can interrupt the presentation anytime if you are, let's say, if you don't have any idea like what the term was, or let's say, for example, there are things that are like super unclear and you want me to translate it for you, I would be more than happy to do that. And you can just say, excuse me, Dr. McMillan, this and that, and then I would just like jump in, and then I will talk in Bahasa. So feel free to interrupt the explanation if you need to. And I think Dr. McMillan won't mind, right?
Not at all. I would encourage it.
All right, there you go. So without further ado, there you go. Floor is yours.
Thank you. Well, thank you for the introduction, and thank you for inviting me to speak to you all today. First, as Rudy said, I would like to make this kind of interactive, and I talked to Rudy about a couple different things about what you all do versus how we do it. But at any point, if you want to share a difference or if you have a question, as Rudy said, please feel free to interrupt. And at the end, we do have a somewhat interactive case. So I would love your participation in that as well. I'm going to go ahead and share my screen with you. Their date of birth and their phone number, their primary care provider, so who the main doctor is, their pharmacy, so where they're getting their medications filled. And we try to encourage patients get all of their medications from one place so that it's easier to catch drug interactions or duplicate therapy. Sometimes that goes great, but sometimes some patients go to different pharmacies. So we have different brands of pharmacies. And some people get them in the mail, so people get their medications from all over. So it's best to get it in one location so that all of the different problems can be addressed. If they have any medication allergies, what medications they're on, and that includes name, dose, why they're taking it. So it's also good for the patients to know why they're taking it, how to take it, when they started taking it, if they're supposed to stop it. So if it's a 14-day antibiotic, the prescriber, and then any special instructions related to the medication. And then the patient can write down any potential questions that they have. But this record's mostly for the patients to have to help them be able to communicate between their different healthcare providers. So next is, yes.
Yeah. Could please go back to the previous slide?
Uh-huh.
Yeah, but the personal medication record. I have a questions to the students and also the teaching staff in Indonesia. It's been a while since the last time I went back home, and it's been 4 years, I think, that I haven't been updating myself with the newest policy and everything. But Dr. McMillan is wondering. She asked whether Indonesia has kayak apakah kita punya, it's like a form, kayak ada form that the patients carry. Jadi pasiennya membawa semacam kertas atau semacam apa ya, daftar obat, kemudian yang seperti yang teman-teman lihat di depan. Apakah hari ini Indonesia telah memiliki upaya untuk mempunyai semacam PMR, the personal medical record. Jadi dengan begini pasiennya bisa selalu dipantau obat-obat apa yang dia gunakan. Sudah ada belum ya? Jadi
Not
pasien
yet.
kalau datang ke apotek, silakan.
Not yet, Apoteker Rudy.
Not yet. Oh, I see. Yeah, so my friend just told me that at the moment we don't have such thing. But this is such an amazing policy to do, I think. This way, the patients are able to know what they get, and they can keep track of everything, basically, including the side effects, or like if they have questions to ask the pharmacist and everything. Like you mentioned in the previous slide, I think it's the medical review. Could you please go back? Yeah, medication therapy review. Since like the patients have lots of things going on and they cannot recall every drug that they get, jadi pasiennya tidak bisa mengingat semuanya. Makanya dengan adanya tadi di slide berikutnya personal medication record, jadi mereka bisa keep track. Nah, pada waktu dia datang ke apotek, ke farmasi, farmasisnya bisa langsung tahu, oh pasiennya pernah terpapar dengan obat ini. Itu yang dimaksud dengan personal medical record. Jadi bawaan atau semacam kayak laporan begitu, apa yang didapatkan oleh pasien dan beberapa informasi penting lainnya. You can go ahead, Dr. McMillan.
All right. Do you want me to try to get a picture? I didn't bring one home of what, like a personal record, because we make really small ones also, so that they can kind of fold out and be fit into the credit card spot.
Wow.
Like in a patient's wallet. So then the patient has it readily available.
That's a very good idea. Yeah. Do you have that? Or if you don't,
I can
that's
Google
fine.
a form. I have a bunch
Yeah.
for you, Rudy, if you ever want to take them back in the lab.
Alright, sounds good. Ya, jadi Dr. McMillan just said that. Jadi di Amerika itu sudah didesain one particular card untuk dia kartu obat istilahnya. Nah, kartu obat ini, excuse me, Dr. McMillan. So does every patient have this, or like do they get this after the visit? Or how does it
So
work?
they should get it, yes. Do they all carry it with them?
Probably not all of them.
We really encourage it. So this is an example of what it looked. I don't know if
Yep.
you guys can. So what it would look like, and you can get them small, and then they can fold up, and then you can just have the patients carry them in their wallet. Because a lot of times pieces of paper, patients are more reluctant to have with them. But if you can write it and put it in their wallet, and then we encourage them to bring it to the visit. So if a doctor does make a change, they can change it on the card as well.
Nice.
And some patients are great with that, and some patients not as much.
Yeah. But at least we have the effort, to provide them with the facility like this. So before we go forward, jadi Dr. McMillan bilang ini kartu obatnya. Jadi tadi yang dipaparkan, kemudian itu bisa dilipat dan dimasukkan ke dompet. Saking memang pentingnya evaluasi terapi obat. Jadi kayak dari hasil diskusi kita sebelumnya, monitor obat. Tapi pasien mana ingat, dan juga I think the names of drugs these days, they are just so hard to memorize. Susah untuk mengingat nama obat. Apalagi pasiennya begitu. Makanya having the, let's say, medication card kind of thing, it's very helpful. Jadi silahkan, I'm sorry. See, I just talk bahasa. Yeah, I just spoke bahasa with you, Dr. McMillan. See, I just cannot distinguish.
Aaron McMillan.
All right, go ahead.
Okay, so this is the medication-related action plan. This is what a note would look like that goes to the patient. So I mentioned briefly earlier that we have documentation for other healthcare providers about what we talk about. This is for the patient and their to-do list. So as you can see, it's not very detailed. It has their name, the doctor, their pharmacist, the date it was prepared, and then action steps, what I need to do. So that left part is what's filled out. Usually this particular example is 2 things. Usually it should be no more than 3 when talking with a patient, because if you give them too long of a to-do list, it can become overwhelming for them, and then they don't do anything you ask them to do. So prioritizing what you want the patient to do is very important. And that should be limited to 2 or 3 things. And sometimes you also, and we'll talk about this a little bit with motivational interviewing, but you want to work on what the patient also wants to work on too, getting a sense of what they feel is important, because you might feel it's important for them to stop smoking, but if they don't want to do that, that wouldn't be a high priority because they're not going to do it, and they told you they're not going to do it. So examples that might include is talking about a diet, talking about ways to improve their medication adherence, so to make sure they're taking their medication, if they need to start checking their blood sugars, so things that they're doing. So not necessarily starting a statin for their cholesterol. That's more something that goes to another healthcare provider. These are the things that a patient needs to do to help make their health better. So again, this is for 2 to 3 things. And then the patient can write in a journal what they did and when I did it, but very few in actual practice would fill that out. But if they do it, that's awesome. And you really encourage them for making those changes. Rudy, do you have anything?
Just a little bit. About the medication-related action plan. Ini kurang lebih sama, tapi it's a different from. It's a different form that is used to keep track, and also like if we have like particular advice for the patients, especially the non-pharmacological steps or treatments kind of thing. Jadi Dr. McMillan bilang, jadi kita sebagai apoteker tuh proaktif dalam menyediakan hal-hal apa saja yang harus dilakukan oleh pasien. Seperti yang kalian lihat di situ action steps, kemudian what I need to do. Di situ apa yang harus dilakukan oleh pasiennya. Jadi memang bedanya di Amerika, the difference between United States and Indonesia is that I think the pharmacists are pharmacists are demanded to be proactive in providing, like education, both like drug-related information and non-drug-related information. Am I correct, Dr. McMillan?
Yes.
Yeah, in that way, with this kind of form or card, ini jadi nanti pasien tahu apa yang harus dilakukan, seperti lifestyle, and then diet, or anything that has something to do with their conditions. Okay, I'm done.
All right. And then intervention or referral. So this is where a pharmacist makes recommendations to other healthcare providers of what should be done. So looking at the medicine, if something needs to be stopped or something needs to be started, or if they need to go see a different specialist or someone else other than the pharmacist. So sometimes they will refer to another healthcare provider. And then the documentation and follow-up, this is more for other healthcare providers. So in the United States, we use what's called a SOAP note. Do you all do anything similar to a SOAP note, Rudy?
Yep.
Okay.
We do have. Uh-huh.
Is it called the same thing?
Yes, exactly.
Okay, so we have our SOAP notes, and each site kind of changes it a little different. I don't know if your education's the same way, where different faculty members and teachers might have you write things a little bit different, but it does have the same components. So there's the S, which is the subjective, and these are the things that the patient tells you. The O is the objective, and these are things that can be measured or seen. So it would include lab values, any physical assessment that you've done, blood pressure, pulses, respirations. The assessment is coming up with the problem. So what's wrong with the patients and their medications. And then the plan includes both the plan that the patient needs to do and then the plan that the providers need to do. So you should also document what you told the patient to do in these SOAP notes. And it's recommended for them to be clear that contains all the information, but also not have it be too long that it won't be read by the doctor. But this helps pharmacists for legal issues, so it documents everything that you told the patient so it can't come against you. And it also tells all the providers what was recommended and what was done. And it's also, if you follow up with the patient on future MTM visits, it lets you know what you told the patient. And then also planning follow-up for the patient. So what labs need done in the future? Do they need to come talk to a pharmacist? Do they need to make a appointment to get their eyes checked or to have a foot exam if they have diabetes? So all the different follow-ups that need done and what you're recommending.
Where do we keep this document, by the way?
The pharmacist?
The pharmacist?
So it depends on what setting that you're in. If it's in a community pharmacy, the community pharmacist would keep that, and they actually will mail a copy of the SOAP note to the providers or do it electronically, depending on how they're communicating. If it's in an ambulatory care setting, it would just go in the medication chart. So when I did these, it just went to the medication chart, and then I might send it to, if the patient went to see a cardiologist, you could also send it to the cardiologist so that they're aware, and it can hopefully go into their medical record there as well.
So no, I'm just wondering specifically, like, is it integrated into the other like clinical documents of patient? Like, let's say that again?
That is the goal, is it's part of their medical record.
Nice. Yeah, if you please, if you could go back to this one. Yeah, just a very quick story about this. Basically, untuk SOAP, SOAP ini dalam bahasa kita, jadi kita sudah semua sama tahu. Jadi subjective, objective, and then assessment, and then plan. Ini saya pikir sudah dilalui semuanya, dan intinya kurang lebih sama, tetapi the difference between us, Indonesia and United States is that ini dokumennya betul-betul digerakkan, tidak hanya pada, it's not only in the hospital, but even di community pharmacy yang apotek biasa itu juga punya, jika memang pasiennya ambil obat di tempat itu, sehingga selalu itu diketahui apa-apa yang didapatkan begitu. Jadi sudah jelas ya. Let me know if you have questions. Feel free again to interrupt. Either you can say, excuse me, Karudi, excuse me, Dr. McMillan, let us know. I will let Dr. McMillan continue the presentation.
I think there is a question from the student.
Oh,
Apoteker Umi.
yeah, there's a question. Yeah. Dr. McMillan, there's a question.
Hey,
in the chat.
hold on. I'm having a hard time.
Oh, yeah, because you're presenting, you're not able to see the chat. I will read it for you.
Okay, thank you, because I can't see it.
All right, gotcha. So, dear Dr. McMillan, if there is a drug interaction occur, and then there is not a chance to switch or any solution to it, can we just monitor the adverse reaction? I think, let me rephrase the question. So basically, after, let's say, if we are taking notes and based on the records that we have of the patient, and then we figure out that 2 or 3 drugs, they have interaction, and at the same time we don't have solution for it, what should a pharmacist do? Should the pharmacist just monitor the adverse reaction, or so what would you say, Dr. McMillan?
So I think it depends on what the interaction is. With drug interactions, there are some drug interactions that are severe and that could cause fatal side effects. And there are some interactions where maybe you need to monitor the liver enzymes. So I would look at the cost versus benefit, essentially. So does the patient need to be on those medications? Is there an alternative? Is what they need to benefit from being on the medication more important than the potential interaction? So I think just looking at what the patient's needs are, and this is again going back to getting that good history on the patient. So what is most important to that patient? What problems are they having? So maybe a medication does interact, let's say it causes drowsiness. But if a patient doesn't feel tired, you wouldn't need to necessarily stop those 2 medications because the patient feels okay.
Gotcha. Yeah.
Does that make sense?
It does. So the point that Dr. McMillan just made was that drug efficacy and patient safety are the priorities, basically. Yang paling penting itu keamanan keamanan pasien, dan obatnya tetap bekerja. Nah, it depends, karena as we know together, there are like significant level of drug interaction. Kalau seandainya masih interaksi yang minor, if it's just like minor interaction, probably we could just like still, if we can evaluate in every 2 weeks, 3 weeks, 4 weeks, or whatever, like the patient comes to us, then that's fine. Tapi in short, the answer is it depends on the level of significance of the drug interaction. You better prioritize the patient safety. if the interaction is so, like fatal, then you better change it. You cannot still give the patient the drugs if they are harmful. Yeah, I think I really hope that it makes sense. Let us know if you still have questions to follow that up. But yeah, I think that's pretty clear.
Okay. Any other ones in the chat?
Nope, that's it.
Okay. All right. So some of the benefits of having MTM, we kind of talked about this before, but it allows the patients to identify anything that's going on, if medications are being used inappropriately, if there are any side effects, if there are any drug interactions, if there are any diseases that aren't getting treated. Maybe a medication ran out of refill and it just got taken off the medication chart. And so being able to identify that, answering any questions that the patient has, helping them improve medication adherence. So if patients aren't taking their medication, they're not going to benefit from their medication. Addressing cost-related issues. So in the United States, medications can sometimes be very expensive, and patients have to choose if they should get a medication pill just because they can't afford it. So either switching to a medication that the patient can afford, or helping them come up with ways to afford it. We have different patient assistance programs, or sometimes you can ask for additional funds to help with your copay for your medication, so how much you have to pay. So that's a big thing that pharmacists can really play a role in doing. Some of the medications can be very, very expensive. Doing administration technique. So this is one of the things that Rudy gets to help teach with this. So to make sure that patients are using their inhalers correctly, any type of injection, because patients aren't getting a benefit if they're not taking it correctly either. And provide any education and counseling that might help them understand their medication. So helping them understand why they might be taking a medication, because that will help motivate them to take that medication.
Yeah, that's so true. I think this slide is probably, like, I would say, the most crucial to be known by the students. I know that. So teman-teman, ini MTM, so Medication Therapy Management. Ini sangat penting. Sepertinya kita punya, dan setelah akhir kita punya mungkin beda bentuk begitu. Kita punya asuhan kefarmasian begitu. Tapi intinya, kalau seandainya profesi kita itu bisa lebih dinaikkan perannya dalam melakukan MTM, atau dalam konteks yang kita punya mungkin asuhan kefarmasian, can you not see, like, these are like amazing benefits that we can yang bisa kita dapatkan dari MTM ini. Jadi mulai dari identify medication related problems, kemudian answer questions for patients. Kalau mereka punya pertanyaan terkait obatnya, tiba-tiba mereka suka berdebar jantungnya setelah minum obat A, obat B, dan seterusnya. Ada improve medication adherence, ada juga address cost issues. Some people, they're not having the privilege of like having lots of money. Jadi there are tons of patients are struggling with drug costs, which is super crazy. It's super expensive. Jadi dengan adanya MTM ini, the pharmacist can pretty much advocate. Jadi si apotekernya bisa mengadvocate agar bisa di lobby untuk mendapatkan potongan, atau mungkin mencari policy atau kebijakan untuk dapatkan pembayaran yang lebih rendah. Kemudian assess administration technique, and the last one is provide education and counseling to improve understanding of medications. Ini juga tadi Dr. McMillan bilang, I have been assisting her in the last point. Jadi kita mengajarkan counseling kepada apoteker. Jadi memang betul-betul masukan pada teman-teman Umi juga. Mungkin betul-betul yang counseling, kemampuan counseling, dan juga titik berat pada ilmu pelayanan itu harus lebih digalakkan lagi. Tapi omong kosong kita bisa bicara tentang counseling obat kalau kita tidak paham apa yang kita counselingkan. Jadi betul-betul kepada teman-teman semua harus lebih aktif lagi belajar. Di sini saya sudah 4 tahun bersama beliau di counseling. Dr. McMillan, there is a question in the chat which is Dear Professor McMillan, okay, this is in Bahasa. How do we convince the doctor to follow the suggestion or recommendation from the pharmacist based on our assessment? Speaking of Indonesian clinical practice area, it seems like some medical doctors tend to have like some of them, they have issues with, like being arrogant, and they don't want to be told what to do, pretty much like arrogance issue, I think. Yeah.
Okay.
Did you?
So we have had that problem in the United States as well.
Yep.
A lot of, we really in the United States are teaching interprofessional education right now to all students. So students in medical school, in nursing school, physical therapy, dental school.
Dentistry.
They're all working together while they're in school, so they understand what each other are doing and what the benefits of a pharmacist is. So I really think developing relationships with the doctors that you're working with to show that you're helping them, because you can take time away from them going through the patient's medical records. So they're not wasting their time and they can get paid more. So really helping those physicians, one, make them feel like you're just helping them. And then once they see that you're making good recommendations or the benefits that they're getting, because in the United States, physicians might get paid more if more patients are at goal. So if their cholesterol is controlled or if their diabetes controlled, they might get reimbursed better for insurance purposes. So it's really showing that we're working together for the patient and not taking over their role. So that's a big thing, is that doctors go to school for a lot longer than pharmacists, and they don't want pharmacists to take over their job, but really showing that we're the medication experts.
Gotcha.
And they're the ones, which is why we can't necessarily always make those medication changes, because we're not medical doctors. But we are experts in the medication. So let us do what we do and let the doctors do what they do. And then hopefully that makes a better patient. So really trying to show what services can be done and just establishing that relationship. Like the place that I did a residency, the doctors loved the pharmacist. We made their life easier. So there were pharmacists there when they had a patient that was on 20 medications and didn't know what to do. They came and got me, and then I sat down for an hour, and they didn't have to. So really showing that you're the expert.
Gotcha. Yeah, so the answer to that question basically, just to make it clear to other students. Jadi intinya, apa namanya, I think the exposure starts from the curriculum of the educations of all health professionals. We do have interprofessional educations in the States, and we do have that too back home. Dan being exposed to all professions. Jadi we need to build the relationships among health professionals, pharmacists, medical doctors, nurse, and everyone basically. Jadi singkatnya, Dr. McMillan bilang, jadi yang pertama itu yang kita turunkan dulu tegangannya. Jadi kita tunjukkan apa yang kita bisa lakukan. Dengan begitu pasti kita dapatkan fungsi yang lebih ini lagi. Di pengalaman beliau, seringkali dokter sangat merasa terbantu dengan adanya apoteker. Simpelnya begitu. But Dr. McMillan, I think the first one, how do we convince the doctors in case if they don't wanna follow or like listen, kinda?
I think that also goes with advocacy of the profession. So nationally getting the respect of what pharmacists can do. And I think really just sometimes it's a slow thing. If you have a doctor that's not receptive to you, slowly showing them what you can do in ways that you can make their life easier.
Nice. Yeah, again, the point is just show them what you can do. That's what Dr. McMillan just said. Jadi teman-teman semua belajar baik-baik, kemudian kita tunjukkan apa yang kita bisa lakukan. Kita tidak perlu mungkin mengemis untuk diakui, tapi kita akan dipakai dengan sendirinya jika memang fungsi kita sudah terlihat. Simpelnya begitu. Kalau memang mereka tidak ingin, teman-teman dokter ini mungkin tidak mengikuti saran kita, mungkin mereka punya alasan. Kita berpikir positif saja, mungkin alasan, mungkin poin terakhirnya itu kalau mereka arogan ya, tidak mau mendengar. Tapi secara general, we are not medical doctors, we are pharmacists basically, and yeah, we just show them what we can do, and we're gonna go from there. Yeah. Okay.
Any other question?
Yeah, I think study case. We're almost there, aren't we?
Couple more slides.
Yep.
Is that okay for timing?
Yeah.
Okay.
We have tons of time. It's still 9 p.m. here. Yeah, we got time.
Okay. So just a couple places where MTM services can occur. So community pharmacies, where patients go in and pick up their prescriptions. Ambulatory care, so these are outpatient settings, usually in a physician's office. Long-term care facilities, so nursing homes where patients are living. Transitions of care, so maybe from the inpatient setting where they were hospitalized and then going outpatient to help them go with their medications. And then telemedicine, which since March has increased a ton, is talking to the patients over the phone. So this can be done from a physician's office. Our insurances are also doing it because it's beneficial when someone is looking at medications, if patients on extra medications that they don't necessarily need to be on. Getting rid of those medications saves the insurance companies money because they're no longer paying for it, or maybe switching to a generic alternative. So some medications might do the same thing, but one costs $500 a pill where one costs $1 a pill. So helping the insurance is a lot of insurance companies hire pharmacists to call patients over the phone and talk to them about their medication.
Okay. Question, can pharmacists do that without consulting? Can pharmacists change the brand name drugs to generic without consulting with the doctors?
So not usually. If a collaborative practice agreement allows for that,
Gotcha.
potentially, like for example, in public health, maybe you have a doctor that writes it and you have a certain formulary, like at a prison system, for example. You can change from something to another based on what you have at that setting. Most places you cannot. So what would be done is a letter would be sent to the doctor's office. If it's coming from an insurance, and insurance could flat out refuse to pay for the medication until the patient tried a generic alternative.
See, yeah, I just asked. It does. I just asked Dr. McMillan that bisa ganti dari merek dagang ke generik seenaknya nggak? Katanya in the United States tidak necessarily, maksudnya tidak selalu bisa dilakukan, tergantung dari setting dari prakteknya. Jadi ada misalnya CDTA yang tadi ada agreement, si apotekernya bisa mengganti kalau memang itu sudah diatur dalam persetujuan yang sebelumnya. Tapi intinya kita selalu bisa membuat rekomendasi, dan jika memang pada kondisi tertentu apoteker bisa melakukan itu. Tertentu ya, itu tanda kutip. Oke.
Excuse me, doctor.
Yeah.
Can I ask?
Absolutely.
Thank you. Maaf, I'm so nervous.
That's fine.
Terima kasih atas kesempatannya. Saya Sirina Saud. Doctor, I want to ask about relationship with doctor and pharmacist, terkait relationship dengan dokter sama farmasis. Itu Kak, kalau misalkan kita di Indonesia, apakah sama dengan di Amerika? Yang saya ingin tanyakan adalah kalau misalkan tadi membahas tentang dokter sama farmasis, kemudian ada pasien membawa resep. Ternyata ketika kita melihat resep tersebut, memang di luar dari tindakan keralasannya dokter, ternyata kita melihat ada interaksi obat atau ada ternyata efek samping atau efek yang tidak diinginkan dari obat tersebut, atau mungkin dosisnya tidak sesuai dengan keadaan pasien. Terus kita berusaha, we call the doctor, kita menelpon dokter tapi tidak diangkat. Kita menelpon dokter tapi tidak diangkat. Kita berusaha menghubungi, kita berusaha mencari di mana misalnya tempat prakteknya, tapi kita tidak menemukan. Kemudian kita melihat ternyata pasien ini dia membutuhkan sekali. Kemudian apakah kita dengan perasaan seperti itu, Kak, dengan maksudnya kita memiliki perasaan bersalah begitu memberikan kepada pasien dan kita tidak bisa melakukan apa-apa? Apakah di Amerika pernah terjadi kasus seperti itu dan bagaimana solusinya? Jadi seorang apoteker yang benar-benar baik untuk menangani pasien tersebut, Kak, dalam kondisi dokternya tidak bisa ditangani. Mungkin seperti itu, Kak. Terima kasih. Thank you, dokter.
Yeah. Okay. So the point of the question is basically about PharmD MD relationship, and then she was saying, I'm hearing echoing. I think I'm hearing echo for some reason. But anyway, no, I don't think so. So yeah, she was asking about PharmD MD relationship, and then she brought up one hypothetical situation. Oh, is it just me? Because I'm hearing my voice.
Hear an echo.
Back. Oh, just me then. Yeah. Yeah. So she brought up a hypothetical situation where she got the prescription. It turned out the drugs on there seem to have like severe or like the very high level of interactions, and then she tried to contact the medical doctors, and then for some reasons like the medical doctor is not reachable, and she has no idea what to do. She was wondering if the similar situation has happened in the States. So going back to the point of the question, PharmD MD relationship, so she was having a dilemma whether like she still needs to fill the prescription, or should she just like follow along with what she thinks wrong. So in this case, probably she won't fill the prescription. So what would you say about that? I know it's kind of confusing. It's just.
I think I got it.
Okay.
If you don't feel that it's safe for the patient, I would not dispense a medication until I felt comfortable. And then even if the physician were to say, I want them on it, I would somehow document that the physician said at this time that this is okay. Like you would say dose okay per physician, so that it wouldn't come back, because pharmacists in the United States are still liable for their mistakes. And we carry insurance to prevent from being sued. So ultimately, if that's what the physician's telling you, and maybe there's something else going on why they're on that kind of a dose, or they felt that interaction's necessary, then you just document it to show that you did talk to the physician, you explained maybe the potential harm to the patient, and per the physician, they still wanted you to dispense it. And then you can also tell the patient what your concerns are and that your doctor still wanted you to do it. So it's ultimately up to them too. But as long as you've covered yourself as much as you can, I guess you dispense it because it is a doctor writing a prescription. But without that verification, if I had any inkling that it wasn't safe, I would not dispense the medication.
So yeah, in short, Dr. McMillan will not give the drugs if, like, but we have to be super sure, okay? because the justifications, our call, it has to have like reasonings or like fundamental foundations why we are saying something wrong. Jadi dalam bahasa Indonesia kita harus yakin dulu bahwa ini memang salah, jangan sampai kita juga yang keliru. Dan yang kedua, Dr. McMillan bilang tidak mau kasih obatnya, tetapi the point that she was making was that we have to protect the patient, but at the same time you better protect yourself, because you have to document if let's say eventually in the end of the day, then you have to still give the drugs after telling the patients what's going on. Ya sudah, kasih saja, tapi document. That way you can protect yourself from getting sued, dari dituntut. Ya, bahasa Indonesianya begitu. Am I correct, Dr. McMillan?
Yeah.
Yeah, okay. Let's move
Did
on.
that answer your question?
Does that answer your question, Serena?
Yes, doctor. Thank you so much.
You're welcome.
Okay.
All right,
let's
so some of
finish.
the, I can go faster.
Yeah, I think so. That's a good idea.
Okay. So some just tips for how to communicate better when doing medication therapy management with a patient is some patient interviewing techniques, or to ask open-ended questions. So how do you take this medication? Why are you taking this medication? Not, you're taking this once a day, or is this causing you any problems, because you're not likely going to get the full reaction from a patient. Also with leading questions, so that means kind of targeting what you want the patient to say, like, you're not allergic to anything, are you? Or this isn't an issue, is it? So it is making the patient less likely to speak up and say the truth. And also asking multiple questions at the same time. So are you taking anything over the counter, any vitamins, any herbals? The patient might forget something and be less likely to include that. So you want to make sure you're breaking things down by question and really creating open-ended responses to have more opportunity for the patients to bring up their concerns and feel comfortable with you.
Mm-hmm.
The teach back method is a way to summarize that the patient understands what you're saying. So asking them at the end of your discussion to kind of summarize some of the things you talked about, to make sure that they know what you're saying and you're just not a talking head to them. Being sensitive to their beliefs and their understandings. So different patients have different backgrounds, and again, that's going into getting to know the patient and collecting all that information. And then strategies for helping to influence the patient. So if you did identify a change, how you make that patient want to change. And that's what we call motivational interviewing. So what this is changes the patient's desire to make that change. And it's kind of 4 principles. So the first is to express empathy. So this is showing understanding for the patient, helping show that you understand that it's difficult for them to make that change, but really trying to show that you care for that patient. Developing a discrepancy, so showing a difference of maybe what their goal is. Let's say they want to watch their grandchildren do something in 20 years. If they currently are obese, have a blood sugar in the 400s, have high blood pressure, have high cholesterol, they might not live to watch their grandchildren be born. So helping them show that you need to make changes now in order to meet your goals later in life. Rolling with their resistance. So not all patients, kind of talking like the physicians that you mentioned that might not be receptive. Patients aren't always receptive to the changes that you made. So working with what they're resistant to help make plans based on what's good for the patient and what the patient's willing to do. And also supporting any success that the patient has. So let's say you're really trying to work on diet with the patient. If they cut out 100 calories a day, celebrate that little success with them. If they started walking for 10 minutes and they didn't walk any before, even though that's not where you eventually want them to be, that's an improvement. So helping them celebrate their achievements helps bring them confidence and the willingness to change. All right. Any questions about that? I don't know if Rudy's still there, but
Yeah, I'm here.
Okay. All right.
If
So
you
this
have questions, no, I was about to say if you guys have, yeah, someone is about to ask questions, McMillan.
Excuse me, I'm so sorry. I want to ask about oh my God. Maaf, my name
Fine,
is
take your time.
I'm introduce myself. My name is Dewi, and I can ask about the biasanya yang saya lihat tadi data yang terkait subjek, objek dan lain sebagainya di situ selalu ada pertanyaan tentang alergi obat pasien. Di Indonesia ini masih kurang pengetahuan tentang alergi obat-obat. Dan pernah saya temukan satu kasus di mana waktu saya mengantarkan nenek saya untuk perawatan, ada pasien yang di ruangan sebelah itu mengalami efek samping dari obat yang menyebabkan seluruh tubuhnya itu kayak melepuh karena alergi obat tertentu. Kalau di Amerika, apakah ada pemeriksaan untuk alergi obat tertentu? Karena tidak mungkin kita mau tahu ini pasiennya punya alergi pada beberapa obat kalau dia belum pernah menggunakan obat tersebut.
I see. Yeah.
Seperti itu
Is
dari
that it?
saya. Ya.
Okay. Is that it?
Yeah.
Is that the only? Oh, okay.
Yes.
Yeah. Yeah. So the question is about drug allergies. In Indonesia, we don't really test people, but I believe we do. Guys, remember in clinical setting di rumah sakit itu kita idealnya, dan seringkali saya perhatikan juga pada waktu saya praktek, jadi kita selalu tes sensitivitas atau tes alergi pada kulit pasien. Jadi kita injeksikan si perawat di Indonesia itu kita mengecek apakah dia alergi terhadap antibiotik atau tidak. Tapi mungkin tidak terlalu dicek begitu. So the question was about drug allergies. In Indonesia, we don't really test the drug allergies, and it's just so hard to keep track on like patients' drug allergy history kind of thing. How often or what is the situation in these states?
So we also don't test for drug allergies. We give the patient a drug, and then if they have a reaction to it, that's when we try to document so that they don't get put back on the medication, which is why we have the allergies on that medication record, or we put it in the medical chart, or it's in our SOAP notes so that hopefully it can be seen at every patient visit and they won't get put on that medication again.
Gotcha. Yeah, so in the States, we also don't really have such thing as in like drug allergy test. However, the difference is di Indonesia, bedanya kalau di Amerika itu kita laporkan, kita buatkan laporan agar berikutnya si pasien tidak bermasalah begitu. And in case of like drug allergies that the patient experience, kalaupun memang ada dia punya si pasien merasakan ada alergi, maka ya pertolongan pertama, I was saying if something bad happened to the patient due to the drugs, then all we need to do is just how to save them, like first aid kit kind of thing, we call 911. Things like that. Jadi, yeah, that's pretty much it. We don't really have such thing too, but we document stuff here more, I think, compared to back home.
Excuse me, maaf Kak, dokumennya itu Kak, apakah memang didapatkan oleh pasien juga? Karena mungkin pasiennya, kan kalau di Indonesia kan biasa pasien biasa pindah-pindah tempat tinggal karena daerahnya kan. Biasa kan rumah sakit lain tidak akan tahu info tersebut dan ada pemberian obat itu kepada pasien gitu.
Ya.
Saat dia masuk ke rumah sakit lain, apakah memang riwayat pengobatannya itu akan diberikan untuk pasien lagi obat-obat yang harus dihindari?
Yeah.
Terima kasih.
Yeah. So the question is, so how do we document the allergy? Is that say in the patient's file, in the hospital, or in the clinics? Because as we know together, the patients, they are all over healthcare providers, private care, whatsoever. How do we document it?
So usually it's all over a patient's medical chart. It's in the pharmacy's computer, it's in a doctor's office, and usually even with allergies, it's bolded or easier to see. It might be a different color or in capital letters, but they really try to emphasize medication allergies here.
Yeah, it's jawabannya ada di mana-mana. And I think the best thing about healthcare system in the US is that we do have pretty good computerized system, and it's kind of centralized. So if the patient, kalau pasiennya pergi ke ER, emergency room, atau pergi ke mana-mana, data dari alergi itu akan tetap terketahui dengan mudahnya karena memang sistemnya yang sangat baik, link. Jadi ketika dia ke rumah sakit ini akan keluar datanya sama ketika dia ke rumah sakit yang lainnya, begitu. Silakan. I'm sorry. Yeah, go ahead, McMillan. Let's continue.
So this is the part I can try to go through a little bit faster. This is how we implement that patient, the patient-centered care process into MTM. So going through the process of collecting, assessing, making that plan, implementing the plan, and following up. So again, collecting all the subjective and objective information for the patient. So medication list, medical history, any physical assessment findings, lifestyle habits, preferences or beliefs, their health and functional goals, socioeconomic factors, so what they can afford, and laboratory values. Assessing is going through all of the things you collect and assessing each medication for, is it appropriate? Is it working? Is it safe? And is the patient taking it the way they're supposed to? Looking at their health and functional status. So are they in pain where they're not a functioning person or functioning the way they want to be seen? What risk factors do they have? So are they at risk for having a heart attack because their cholesterol is too high or because they're smokers? Factors, health literacy. So sometimes if patients don't understand what they should be doing just because maybe words that they're not used to were provided, or they didn't feel like they were treated nicely. Access to medications. So this goes again to being able to afford medications. Some patients live in very rural areas where they can't get to their medications. Looking at their immunization status and any need for preventative care. So are they seeing a dentist? Are their eyes getting checked if they have diabetes? Are they having foot exams? So looking at the full picture. And then making a plan for that specific patient. So identifying any medication-related problems, making recommendations on their medication, setting goals for their treatment, engaging the patient. So that's, again, with motivational interviewing, you want the patient to feel like they're in control and having power over these decisions. And then providing any follow-up or transitions of care. And then implementing it is just actually doing what the plan said. And then follow-up includes monitoring what your plan did. So if you're starting a new medication or changed a new medication, you want to look at it for appropriateness, effectiveness. If they're having any side effects, are they taking it? If they're meeting their goals, and any clinical endpoints that you're looking for. And then again, going back to that SOAP note, just to show how that PPCP is going into it, the subjective and objective are collecting, the assessment is assessed, and then the plan, excuse me, is to the implementation part and monitoring and follow-up. All right. So going to the patient case, do you want me to, does anyone have questions about that? Or Rudy, did you want to just ask that at all?
I think everything's clear. There are just a few questions in the chat.
Okay.
You can answer it super quickly, and I will just like read it for you. I'm hearing echo again. I don't know why, but anyway. In the States, can pharmacists diagnose diseases?
No, pharmacists
Okay.
cannot diagnose.
Okay,
We can
clear.
screen for things and suggest that what we're finding. So if we do a test in the outpatient, we might be able to look at their blood sugar levels and suggest that they could have diabetes to go see their primary care doctor. But
Gotcha.
we cannot diagnose. You can ask them to go get checked for a certain disease, but you cannot diagnose as a pharmacist.
Yep, clear. So, no. Apoteker tidak bisa mendiagnosa. Second question, in telemedicine, this is in bahasa. How can we tell that the patient's telling the truth about the side effects of the drugs or the symptoms that they're feeling? Because everything basically from far away.
And that's where open-ended questions comes into play more, because I think it's easier to say, oh, yeah, I do that, versus coming up with what you're actually doing. So that's where that patient interview is really important in getting the truth out. And then making your patients feel like they're comfortable talking to you so that they don't have to lie to you about what they're doing. So making it so you're not judgmental with them and you're helping them achieve their goals. So maybe trying to make the patient feel like you're on their side rather than interviewing, because if they're lying, they're not doing anything for themselves.
Correct. Ya, jadi memang intinya kita tidak bisa menjamin mereka mengatakan yang sejujurnya, tetapi yang kita bisa lakukan adalah membuat mereka comfortable with us, and then they will tell us the way the symptoms are. Pokoknya ada tekniknya, dan ini barangkali Ibu Rizky patut diajarkan kepada adik-adik untuk bagaimana melakukan pendekatan kepada pasien untuk bisa menggali lebih dalam. Salah satu caranya itu yang open-ended question yang tadi disebutkan. Bertanya tapi tidak hanya iya atau tidak, tapi kita menggali informasi. And the last question would be, don't you think that telling the patients about the side effects of the drugs might have impact negatively to their adherence?
Potentially, but I think that in the United States, we also have commercials where it might list, and patients Google things and it lists every potential thing that could ever happen to a patient, versus talking to them about how rare something is or what symptoms to look for before it gets into a scary side effect and the potential benefit that they're going to have from it. So talking to them about, if you start to feel this way, that's okay, or call 911 immediately. It's really rare that it'll happen, but making them feel comfortable and telling them the signs to look for before something bad can happen.
Ya, katanya ya mungkin bisa menyebabkan reduced adherence, yang menurunkan kepatuhan, tetapi ya itu kadangkala harus dilakukan. Ya, yang paling penting adalah menyatakan atau menjelaskan secara baik dan benar sehingga pasien tidak perlu takut, karena itu memang nyata adanya. Kalau di Amerika sendiri memang kita seringkali menyatakan itu, bahkan iklan-iklan di TV atau di YouTube itu kalau ada iklan obat, every single ad that I know of on YouTube itu ada side effects-nya, disebutkan satu demi satu. Jadi the side effects are mentioned in their ads. But yep, that's it. Let's go to the case.
Okay, so I've given you all, do you all have my slides already? Do they have them?
Yep.
Okay, so I've given a case for a patient. So the information that you have is stuff that would be in the medical record. So it's a 57-year-old white female. Her past medical history includes type 2 diabetes, hypertension, COPD, and depression. Past surgical history is none. Allergies is no known drug allergies. So this again goes, they might be allergic to a medication, but none that we know about because we also don't do the testing. The vaccine record. So she had an influenza vaccine this year, a Tdap, the Pneumovax, which is the PPSV 23. I don't know what you all call them, the full series of hepatitis B. And she's up to date on all of her childhood vaccines. Her current medications include lisinopril 40 milligrams, metformin 500 milligrams, Ozempic, which is a GLP-1 agonist injected subcutaneously once a week on Sunday, sertraline 50 milligrams by mouth, Spiriva or tiotropium handy inhaler, Proair, a multivitamin, and Tylenol. Here are her vitals. So her blood pressure is 118/76, pulse is 76, weight is 230 pounds. And then there's her labs of note of things that you might want to look at. Her glucose is 201. Her A1C is 9%. Her cholesterol is 263. LDL is 182. HDL is 30. And triglycerides are 254. Her 10-year risk of having a MI or ASCVD risk is 33%, and her CAT score, which is for her COPD, is low at 8. So usually less than 10 is considered low there. So that's the information from the chart, and we're now going to meet with the patient. So I don't know how interactive we want this to be, but what are some questions that you would want to ask the patient? Or do you just want me to give it? Rudy, what do you think?
Let's ask them first. Do you guys have any questions to ask the patient in this particular case? Kalian punya pertanyaan? Based on the information that we just got in the previous 2 slides, kalian mau tanya apa kepada pasien?
Yes. Family history.
Family history. That's the first one I have on my list. Great job. So
nice.
Mother passed away from heart failure at age 85, and father passed away from a heart attack at age 81.
So, excuse me. So basically, Dr. McMillan is providing us the answers from the patient. Jadi ini ada pertanyaan. Let's say we ask family history, and then this is the information that we get from the patient. Oh, ternyata pasiennya her mom passed away from heart failure, ada gagal jantung at age 85, and then her dad also died from a heart attack. And then what else? Apa lagi? Pertanyaannya, what are the other questions?
So some things that you would think about automatically when you see cholesterol levels that way, a weight of 230 pounds, and blood sugars at that level. What's something that you think about that might not be in the chart?
What are the other questions that you might want to ask that has something to do with cholesterol, or pertanyaan apa yang mau ditanyakan?
Social history.
Social history. Excellent. You guys are going in order too. All right. So first thing we might want to ask is her smoking status. So she smokes 1 pack per day for the last 38 years, and she is not interested in quitting at this time. She drinks alcohol socially, so 1 to 2 glasses of wine a few times a month. She does not use any illicit drugs. Her caffeine use is 1 cup of coffee every morning and 1 to 2 cans of regular soda. So that we call as the non-diet soda with lots of sugar in the United States. Her exercise is none. Her diet is she eats fast food for lunch on most days. So do you all have fast food, Rudy?
Yep. We do have KFC, you name it. Oh, we have
McDonald's,
California.
KFC, parties, most days. She does cook dinner at home and snacks on candy and chocolate throughout the day.
Tapi kasih tahu kalau ada yang
So
telepon
that's
Kak
her
Nak.
social history.
Kamu
How
ada
about any
laptop?
other questions you might want to ask the patient?
Any other questions? Let's go back to the I don't know, diseases probably.
Yep. So one more, we could just talk about medication adherence. She misses her oral medications at least once a week. So she does remember her injection, her GLP-1 that she takes on Sundays, but for her other oral medication, she does admit to 1 day a week. And then exactly like Rudy suggested, going into each specific disease state. So for diabetes, you might want to ask when her last eye exam and foot exam were. So it's recommended to have a dilated eye exam and have someone look at your feet at least once a year. She is up to date on that. And then what her blood sugars are. So in the morning, her blood sugar ranges between 170 and 210. And 2 hours postprandial, it's 240 to 275.
Okay. And before we go forward, guys, please try to remember like these information. So this information is so crucial for us to determine the medical problems later on and also the plan.
Okay. And so just to remember, so morning blood sugar is 170 to 210 normal.
I see.
So that's above goal. We usually like to see that less than 140. And then the postprandial blood sugar is between 240 and 275. So that's also high. So thinking about our assessment later, we know that that's a high number.
Gotcha.
So next is the COPD. She says she has no breathing problems and she uses her ProAir once a week or less. In her depression, she feels controlled. No issues with that. All right, so that is our patient information that we have. Again, you want to think about those things, and we're going to come up with our assessments or patient-related problems. Does anyone want to volunteer any problems before I give them to you? Or Rudy, do you think it's best just to provide them?
Yeah, let's just ask them.
Okay.
Kira-kira, I'm hearing echo again. It's so no. Hello?
Yeah,
I don't know why. What's wrong with my computer? Yeah. So Dr. McMillan is asking you, based on the information given, what are the problems? Do you guys think? Yeah, you can talk. Hello? Yep. What are the problems, do you guys think?
Yang pertama,
Yeah, go ahead. What is the problem? What you want to say? Yeah. Hello.
If you feel more comfortable, you can type it into the group chat. I don't know if that.
Yeah.
yang pertama terkait riwayat keluarganya, riwayat keluarganya kan di situ dia ada.
So Dr. McMillan, she said that it has something to do with the family history that might increase the high risk of the patients having or developing heart-related condition. That's number one.
So she is at risk of developing things. So she might need to be on an additional medication for that.
What else?
Or do you know a medication that might benefit her based on the medication that she's taking? What are a class of medication based on that would help her to not develop a heart attack?
So Dr. McMillan is asking you, what are the medication do you think that would take care of that issue? Obat apa yang digunakan untuk menangani the high risk of developing heart-related condition?
Statin.
Excellent. Yes. So the
Yep.
patient is a candidate for a statin therapy. Good.
And then
What
what
about
else? What else?
her disease states? Is everything controlled based on her current diagnoses? So type 2 diabetes, blood pressure, COPD, and depression. Are there any problems with any of those?
Any problems with the disease, do you guys think?
Sosialnya gaya hidupnya pasien terkait.
Yeah, so she just said that the lifestyle of the patient.
Yes. So the lifestyle, she does not make some of the best choices. What disease right now does it look like is maybe not controlled based on some of her lifestyle choices?
So what disease yang jadi masalah utama di sini?
Coffee, junk food, and
Yes, that's the lifestyle part. Yeah, so the fast food and everything, that's the lifestyle. And the next question would be seeing the information in front of you. In the disease part, masalah utamanya apa nih yang belum terkendali?
gula darahnya, Kak. Glucose.
Yep, she said blood sugar.
Yes, perfect. So her diabetes is not controlled, likely needs more medication and a couple other lifestyle modifications. Excellent. How about her vaccines? Do you notice any that maybe she might not have taken that she would be qualified for?
I'm gonna jump in. To be honest, I personally, vaccine-wise, we're not really.
Because you guys don't get that.
Yeah, yeah,
Okay.
you got it.
So the herpes zoster, which is a shingles vaccine.
Oh, we do have MMR though.
Okay.
Measles. Mumps and rubella.
That would have gone under her childhood vaccine. So we get those when kids turn 1 is when they start that series.
Yes.
In the United States.
So vaccine-wise, probably we can excuse them for that because I don't even know what vaccine that the patient probably might miss.
Okay, and we use the Centers for Disease Control, or CDC, does come up with a nice little chart that as pharmacists we can go to, and it easily shows at what age the patient needs for each
schedule, yeah. Nice.
Yeah. And then going back into lifestyle, we'll just jump to what it was. Some of her choices that she has made is her tobacco use and her non-adherence to medications. And again, unhealthy lifestyle. So a couple problems, a couple that we might want to, recommendations we might want to make to a healthcare provider, and a couple we might want to make to a patient. So just kind of going through what a plan might look like. For a plan for the patient, this is the previous slide, it says she needs insulin therapy. So we would recommend starting insulin. So if that does happen, you're going to want to review how to administer the insulin, how frequently, maybe storage issues for the patient, how to dispose of the needles, and insulin can also cause blood sugars levels to drop. So we always teach patients on insulin how to recognize the symptoms of low blood sugar and how to control.
Kayaknya Mami terakhir ini bukan plan nih, Bu. Plan nih, Bu.
Recommendations for lifestyle changes. So decreasing her fast food intake and
Mau mi
and
supply
her
ini.
candy,
Kan ini
exercising
sudah plan
with
nih,
a
Bu. Selesai
goal.
plan, selesai nih.
Now this is per rules of a goal of 150 minutes of moderate intensity exercise weekly.
Ya, Bu.
For patients that do nothing,
Ini kan
you
sudah
cannot
plan,
tell them
berarti selesai
150
nih, Bu.
minutes
Sudah
right
plan
away
nih.
because they will not do
Iya.
it. So leading in slowly.
Bareng
So
nih, Bu,
maybe
sampai
adding
plan.
one trip around the block every morning, and then the next time you see them two. So this is really, again, making that patient want to make the changes. Because if you tell somebody that does no physical activity to go run 150 minutes a week,
they won't do it.
they're not going to do a thing. So that's one of the interviewing
Kan sana di
things
luar,
that
di
you
luar,
want
di
to
luar, di
get,
luar, di luar. Nggak bisa di sini, nggak bisa
and
di sini.
helping them achieve goals that are realistic for them.
Kenapa itu, Vika?
You want to provide
Kenapa itu,
strategies
Vika?
for improved medication adherence. So a pill box, setting reminders, maybe moving the location of their medication to somewhere they might remember it, setting an alarm, something that works for the patient. So they might be able to put something in their cell phone. If the patient isn't good with their cell phone, you wouldn't want to have them put an alarm on in their cell phone. So working with what the patient's doing, or working with how they go through their day to help them remember to take their medication. So if she's having coffee, maybe putting her medications by her coffee pot so she takes her medications in the morning when she drinks her coffee. So something like that works with the patient's lifestyle. And we said that the patient is not ready to quit at this time, so we wouldn't want to necessarily provide her ways to quit. We would just want to continue discussing the benefits of smoking cessation. So if we tell her to try the nicotine patch to help her quit smoking, she's not going to do anything with it because she doesn't want to quit right now.
Yeah.
So that's, again, focusing on what the patient's goals are. So we know that that patient needs to stop smoking. We know that she needs to stop having fast food and cut out candy completely, but making goals for the patient that she can achieve. And then again, at the first visit, limiting it to 2 to 3 goals at a time. So what's the most important? So if we start this patient on insulin, I would say educating her how to use it would probably be the most important thing.
Yeah.
And then maybe taking her medications might be the 2 things that you aim for at that visit. So even though all of those issues are important, figuring out what's most important for that patient and what the patient feels is most important, because you want that patient to be involved in your decision. And then recommendations for the healthcare provider. So I just said initiate Lantus Solostar, so that's a long-acting insulin, subcutaneously once daily. Initiate that moderate to high-intensity statin, and administer a Shingrix vaccine, which is the herpes zoster. And then coming up with the follow-up. So call the patient in 2 weeks, check their blood sugar, check their insulin use, see if they're remembering to take their medications, how their diet and exercise are going, assessing the desire to quit smoking. So now that you've told her about the importance of smoking cessation, does she feel like she's ready to do that anymore? And sometimes when the patient starts making small changes to get healthier, they're empowered to do bigger things. So checking on that, excuse me. And then in terms of monitoring labs, in 3 months, you'd want to check the patient's A1C to see if the insulin's doing anything, cholesterol, now that you recommended a statin, to see if it's going down, to check her liver function tests, because that's a side effect of cholesterol medications, is that LFTs can go up. So that's kind of just a quick MTM of a patient. What questions do you all have?
Do you guys have any questions? I think, so basically those plans, I'm hearing echo again. Yeah, so those plans go based on the problems that the patient has, pretty much. Okay, Dr. McMillan, do you wanna stop sharing your screen? And so we will be face